We record this, Julie, just so
Okay,
you know. Okay,
got it.
so, right, if anybody has a problem with it, we ask them that they disconnect now, and I'm just gonna go on mute, and I am going to continue admitting people because they're popping in. Everybody, this is a really, really big honor for us to have Julie from the CDC and to talk about everything that is being done and where the CDC is headed for their traumatic brain injuries. So research. So go ahead and take it away, Julie.
Thank you, everyone. I'm very honored to be here today. I've been in, this is going to date me, but I've been in the field for close to 40 years. I was a speech language pathologist in clinical practice prior to becoming a researcher. And I worked in hot rehab units in Pittsburgh. I helped establish the unit at National Rehab Hospital in DC. And then I went back and got my PhD and got into research. And what's really motivated me is what I learned from working with individuals who've experienced brain injuries. And it's my 10th year at CDC. And what I like about this and what I'm going to talk about today is we can look at things at a national level and look at what is the burden of TBI. So I'm going to give you some examples today, and all of this information is available on our website, or most of it is, at cdc.gov/traumatic brain injury, and that'll be at the last slide as well. So this is not news to anybody on this call, but this is what we consider a brain injury at CDC, and we are funded specifically for traumatic brain injury. That we're a line item in the congressional budget, and this is our definition about what it is and what happens. So one of the things we do is the epidemiology of TBI, and as a former clinician, I was new to this field, but now I think I've become one. But we have a survey, we do something called surveillance reports. So we published one in 2019 that talked about emergency department visits. And this was before the codes changed over. So as you can see, we could document the number of emergency department visits, which I like because that includes all severities of TBI. We learned from this data that the highest group experiencing TBI in terms of age is age 65 and older. The second is 0 to 4 years. So the two most vulnerable groups across the age span. And lastly, adolescents 15 to 24 years and young adults, mostly the upper two are mostly from falls, but these ages 15 to 24 years are mostly from motor vehicle crashes. So then we looked at recently in 2021 hospitalizations. And again, these are mostly adults older than 65 that are hospitalized as a result of TBI. We also looked at traumatic brain injury related deaths. We do not want people to follow this, but this does happen. And suicide and unintentional injury were the most likely causes of these deaths. We also look at, as you know, we've done a lot of work in youth sports. And so we wanted to see what was happening. This was published a few years ago where we looked at what sports were kids most likely to have brain injuries. And as you would suspect, it's contact sports such as football. But it also happens in other activities that children experience. Now, this is a report. This is a different way of looking at the incidence of TBI, because this is a national survey, the National Survey of Children's Health, where parents are called and they're asked, has their child ever been told by a doctor, a healthcare provider, that they experienced a brain injury? Now, this incidence is slightly lower because these are people who were seen in healthcare settings. But what we learned from this is what percentage of children have a history of TBI and health conditions associated with this lifetime history. So we were able to compare those who said, yes, my child has had a history, to those who said no. And as you can see, there's more health conditions associated with TBI. This paper was one of the starts. We did this with Children's Hospital of Philadelphia, where we looked at their entire healthcare system and said, where are kids going with mild brain injury and concussion? And what we learned is they aren't necessarily going to the emergency department or urgent care. They're seeing their primary care physicians. And this started the conversation about the undercounting and underreporting of people who do go to the emergency room. The other thing, I'm really proud of this work by my colleague, Jill Dockery. We have a whole website about health disparities now, indicating who's at risk, most risk for getting a TBI. So racial and ethnic minorities such as American Indian, Alaska Natives, non-Hispanic, Black and Hispanic patients. So this is documented on our website. Military service members and veterans. And one of the things that's coming up now is there's more investigation on blast injury because that's a big contributor to TBI in the military population. People in correctional or detention facilities. And one of the things that we learned back in 2010, CDC had work about this area. We learned there's a very high rate of self-reported brain injuries in the justice system. And some researchers have investigated that further and have screened individuals in these systems. And we're learning more and more that this is a big concern, that people in correctional and detention facilities have a very high rate. People who experience homelessness, they're 2 to 4 times more likely to have a history of some kind of TBI. And again, we do not want people who experience a TBI to go to this homeless situation. We want to try to prevent it. There's a big push right now to examine survivors of intimate partner violence and domestic violence. These people have most likely to have a brain injury. People with lower incomes and those without health insurance have less access to TBI care. So initially, emergency departments often have to see you for treatment, but then after you're stable, we know that people who don't have insurance are less likely to get taken care of and monitored. And people living in rural areas have a greater chance of dying, but we also know that people in rural areas are not getting access to care like they would be in a metropolitan area where there's a big university hospital. So that epi data that's something that CDC, that's really part of our role to look at primarily what is happening with TBI, what are the effects, what are the burdens. So now I'm going to talk about some work we've done to better understand the effects of TBI. And there's limited study on TBI related disability. This is an older one, and actually it's showing quite a few people living with a TBI related disability. But what we've learned over the years, and one of my interns, Dr. Akila Heggs, created this diagram back in 2015, which I like to show because disability is just one aspect of an effect of TBI. People can have health effects, long-term health effects. They can have a change in their life quality, but they may not qualify for a disability. And social outcomes can be affected. As I indicated, they may be in the justice system or some system where we don't want them to be. So we're kind of looking at this in more detail. What are people experiencing? I want to mention a little bit about our work in children because that has been a primary emphasis. And as you can see, we did a report to Congress on the traumatic brain injury in children released in 2018. These are the authors on the report. We also have one on epidemiology and rehabilitation, which was released in 2015. But I'm going to use this as an example. And one of the nice things about a report to Congress is we do research the literature, but we can also talk about what we know about programs. And I published this article right prior to the report to Congress because I wanted to highlight the fact that children and their families experience two models of care for TBI. One is the healthcare setting and one is the school setting. So they just aren't taken care of in one place. There's two places that we have to consider work. So Congress mandated us to write this report to Congress. That's what I want to mention. They really wanted us to look at what was happening in children. And one of the things we did, we tried to identify healthcare gaps, school gaps, and community service gaps, and policies, and offer specific recommendations. So these are the things that we talked about specifically. We wanted to make sure that all children who return to school are monitored. There's a big need for coordination of care across medical and educational settings, training for educational professionals. There's a lot of transitions, that children experience all throughout their school career, but also from pediatric to adult healthcare is a transition. And one of the main points we made about this is we really need longitudinal studies to better understand where children land as adults. Are they graduating from high school? Are they getting into secondary education? Do they have jobs? So this is a sign, these three terms, we want to recognize traumatic brain injury in children. We want them to be monitored over time. And if they need care, we want them to get care. A few other CDC projects that I want to mention. So back in 2016, we worked with traumatic brain injury model systems to better understand what was happening with adults. Now, traumatic brain injury model systems only covers adults who have experienced inpatient rehab. So it's a limited population, but we were able to make some gains in the literature about what's happening to these adults over time, because model systems has a 20-year data set. And we do have these on our website, where we talk about moderate to severe traumatic brain injury as being a lifelong condition. And I'm sure many of you are aware that there's much talk about traumatic brain injury as a chronic health condition in the field. We also at CDC have started something called the National Concussion Surveillance System. And we're hoping that this would give us more information, including who maybe had experienced a brain injury, but did not seek care or could not access care. This is just getting started. And actually, today at Hill Day, our team lead, Matt Briding, plans to talk about the results from our pilot study. But we're hoping to continue this surveillance. We've also released in 2018 a guideline for diagnosis and management of pediatric mild TBI. And we currently have 2 projects that we are funding to look at the effectiveness of these guidelines and see how they're being implemented. In particular, one thing we wanted to talk about was, making sure families leave the healthcare setting with discharge instructions and they know what to do to take care of their children. We also have a whole heads up program on our website that is it's geared to youth sports and children, but we've updated some training sessions for healthcare providers. This is an example of our at school training, and we recently added one for athletic trainers. Now, I'll just mention briefly, because we have some big projects on return to school after TBI. We awarded 2 projects in 2019 that are going to end at 2023. But as many of you know, school has really changed during the pandemic. And so it's been very tricky on recruiting people, but one is at University of Oregon, and what they're doing is they're comparing an existing program in Oregon with a state that does not have an existing program, so we can better learn what's working and why. Also, Case Western Reserve University is looking at the Pennsylvania Brain Steps program, comparing it to what's happened in their state of Ohio, where they do not have a formal return to school program. And lastly, in return to school, we partner with the American Academy of Pediatrics with this ECHO project, where pediatricians in rural communities receive training on return to school and how to disseminate information to their local schools. So this is our attempt to try to reach out to rural populations. So I've given you some examples of our projects. Please go to our website, which I'll give you at the end. But really, what we want to do is make sure that research is being done, and what we're learning through research studies is directly going to practice so that we know better what is happening to people living with a TBI so that we can prevent some of the adverse outcomes that we hear about. And I want to make this final point. As you know, TBI is not just an event. It's something that can follow people throughout their life. And we want to make sure that individuals living with a TBI have the quality of life they would like to have. So I'll show you you are welcome to email me with questions. And there's our website where we have all these materials. And I look forward to being part of the discussion and hearing what people in this group are thinking about our work at TBI and how we can improve it.
That was
Thank you.
amazing. Thank you. Thank you so much, Julie. We do have some questions that popped in on the chat, and it's going to start with the homelessness topic briefly mentioned. And the question is, how do you prevent homelessness when domestic violence shelters are largely to capacity in North Carolina as well as other states? So what are the resources to help people? And the staff do not recognize nor understand TBI. And there's many people on our dashboard that report how they have to couch surf, to live in their car. They drive around in their van. And in particular, they stay under the wire simply because they are fearing for their life because of the assault that they had. So that's a really important topic. So I'd like to take that one first.
Yeah, very important topic. And I don't have all the answers to that, but I think some states are doing things to train caseworkers who go into these shelters on recognizing traumatic brain injury. What I reported on is we know people who experience traumatic brain injury may end up in homeless. And outside of CDC, I help run a free clinic in Georgia. And what we've learned from that is what was mentioned, homelessness after TBI. So people may lose their job, so they can't pay for their living place. So they're living with family, but they're not living where they want to live. Or they're living in the Y or different places. And especially from domestic violence shelters, yes, they are becoming overwhelmed, aren't they? So I think some of the ways to prevent the effects of TBI in this is that people in those shelters have been trained in some states. I don't have any specifics. I'm just telling you what I've heard about. So training staff to recognize a TBI and where to go for help in your specific community is one way of doing that. There's a new special issue of the Journal of Head Trauma Rehab that focuses specifically on intimate partner violence. That is very worth reading because the people who submitted publications are really doing the research work to try to better understand the burden of this and how to help people. I think understanding what is happening is we do. I think people in this group really understand, but getting it out there in the public health sector so that we could determine what's the best thing to do, I think is the next step.
I'm gonna echo those statements that you just said. Some of the data that we collect are these real world experiences when people input their narratives and things like that. And so we're really starting to learn way more about the real world evidence and everything that is coming out for people that we never even thought existed. So it's really, really impressive because it's all of their narratives, it's all of their data, and we're putting it into charts for them to empower people to go forward. So with that, there's many other initiatives that we've started, Brain Injury Association of Georgia, we're partnering with them as well. so that we can help them get this data into the brain trust funds and increase the outreach for their people there. But also our members are doing a lot of their own initiatives. For example, one of them, Jordan, who's coming from North Carolina, he is actually heading up a golf tournament to help support neuroinflammatory research using cannabis. And I know cannabis is, a big hot topic now. And I don't know if you have any thoughts about that, or maybe guidance for him, anything like that.
Yeah, that is a hot topic right now, isn't it? And no, we haven't done any work in that area. So unfortunately, I don't have any guidance for you other than I think it's worthwhile that it's brought to the attention of the state and the importance of that work and raising money. So I don't have anything to add, sorry, to that question.
That's okay. I also know that it's in the link, or the link for the tournament, just so everybody knows, is in the chat that Jordan there. But Rob, I was actually getting to you in the veterans. So bomb blasts are a huge issue. When I was at NICO, and for people who may or may not know, NICO is a specific branch within the Defense Health Agency, part of the DoD, or used to be part of the DoD. It's its own branch now, but it's for the soldiers, the wounded soldiers, the men and women that need to go back into battle. And I saw a lot and I learned a lot. But that was where I learned about bomb blasts and its intensity. And we are often trying to get in some grants to assist veterans in particular. But in Rob's work, he does specific hyperbaric oxygen chamber therapy, which is very, very positive. I know, again, firsthand that they would put the astronauts and all of the Top Gun pilots in these chambers because of the G-forces. So does the CDC have any, whether it's input or thoughts or anything about hyperbaric oxygen chamber for the veterans? And Rob, if there's something specific I missed, because you're looking for efficacy, please jump in.
I should just mention, Doctor, we're trying to change the language of medicine to talk about traumatic brain injury as a brain wound. A wound. The principles of wound healing are well known, decades and decades, hundreds of years, but you can't heal a wound without oxygen and energy. And the consequence of talking about or subsuming brain injuries as a mental health problem kicks it over into a whole bunch of symptom palliation strategies, not brain wound healing. I'd like the CDC to adopt the language of brain wound healing, but I'd love your comments on the role of the CDC in drawing attention, which is to say informed consent. Everyone on this Zoom call has maybe heard of hyperbaric oxygen. Doctors are not taught it in medical school. It's the damnedest thing. I'd like your comments on how we transform the way we approach healing as opposed to palliating symptoms.
Oh, thank you. Great question. And as I said at CDC, our role isn't necessarily in interventions, but it's more in trying to bring attention to the burden, right? So I know that I think it's NIH has funded a study on hyperbaric oxygen in the country. So that's good because federal agencies are considering examining that. That would not be our role, but our role, what I've enjoyed, I've been on some federal interagency groups where we've talked about the burden in the military. And prior to the last few years, blast injury was not recognized as a TBI mechanism. And now it's coming to the forefront, and people are and people in the services in the military, they weren't diagnosed promptly and didn't have access to care. All of that is changing, which I'm really glad about. And part of the reason it's changing is people at the federal level are looking in more detail about definitions, like blast injury is a mechanism. And so from that end, I think we're bringing attention to it for the military. I think the hyperbaric oxygen, there is some research being conducted in that, and hopefully that will bring attention to what you're trying to do.
Mhm.
I should just add, and thank you for that, there are 20 randomized controlled trials worldwide demonstrating safety and efficacy.
Good.
5 US government studies at the cost of $186 million.
Mhm.
Data indicates safety and efficacy, and we can't break through to get it an approved indication, even though the FDA has approved hyperbaric oxygen therapy for 14, 15 indications, 4 of which are almost similar to brain wounding.
Yeah.
The
Well,
data are conclusive.
it takes folks like you to advocate for it. And
And
I
folks
think,
like you on the inside, doctor, to let people know.
well, we have talked about those interventions, but I think what I find gets things going is collaborations. So if you could collaborate with some physician groups who may be the ones prescribing that kind of treatment, that may be helpful to you, and make them aware of the literature. I think the literature that's coming out is showing some positive effects of that kind of treatment. Also, biomarkers. There's a lot more research on biomarkers that I think will help inform the physiologic aspects of TBI. But I always tell those researchers that's one aspect of TBI, because people living with it, how you respond to things behaviorally is just as important. So you might not have the physiology, and I think understanding physiology is particularly important for mild traumatic brain injury, because many people have told me over the years the doctor doesn't recognize their condition. So they're hoping that biomarkers come out so that you can measure physiologically, yes, you did have a mild traumatic brain injury. So I think all of this is important, but I do think it's emerging, and it's going to take advocates like you to get it out to the clinical field.
I want to jump in on a quick comment. We have 2 comments in the chat that are I think they're tangent to one another, but to your point about the care and the biomarkers, you know, spot on, right? That goes along with the mild, moderate, severe bucket that is just so random, shoot from the hip. So one of the things that we're doing is actually working on calculating a true severity score with MITRE, one of our strategic partners as well. So it's not that we want to challenge the Glasgow coma scale, but it's not applicable unless you're in a coma, right? And not everybody, as you now saw and presented, the majority of cases are not that. So along that same vein, we also are working with some strategists to help us. People don't get healthcare coverage, you know, insurance coverage. I had 2 insurance plans with my daughter, and Fridays were my fight day. I had to spend the entire day on the phone calling and, you know, talk about, and what we're not even addressing. And Cassandra and I and BIAG just had a caregiver focus group, because now we have invited doctors electronically to come in and look at our platform, look at the data, talk to the people and see what's going on. So we are trying to get it so that if we can help people really look at what is the right course of therapy, it's going to be a step in the right direction instead of a shoot from the hip approach, right? The standardization across the board. So on that note, that's something that we're working on, folks, that I think also ties into what Julia said with the surveillance and it's so understudied. Like, we are truly at the very beginning of what's going on in the TBI world. But the comment also came from Cassie and Stephanie. And I do think that they parlay to one another. The problem and the challenge with the shelters is the underfunding. And so what Cassie was talking about is that working with the brain trust, which you and I were discussing at the very beginning, the brain trusts have the money, but they need more data, right? They need something more than this is how many phone calls. They need to know, what is the profile? What are the injuries? What are the resources? What can we do, right? And so it is all about data. I hate saying it, but doctors like data, right?
Yeah, and I will tell you what's exciting to me is when I started in the TBI field in the 80s, there was no research. And now there is a lot of research on different aspects like outcomes, how many people have it, what are the biomarkers. So some of it's just emerging and we hope to learn more, but there's a lot being done. And part of that is advocates like you, all of you, keep asking questions and asking for things to be done. So keep in touch with your congressman. And like I said, at CDC, we are mandated very specifically on what to do: traumatic brain injury, primary prevention, epidemiology, and looking at outcomes, how we can reduce adverse outcomes. But each federal agency has their mandates and they have to operate under that. So
Yes.
I would say keep up this great work. And I have time, I think, for one more or two more questions.
Okay, all right. And people are asking if they're going to get access. So can I let them know you'll be sharing a Dropbox link with us and we'll send it out?
Well, I can't share my slides, but you can go to our website. All of the information I talked about is on our website.
All right. All right, it is 3:32. Do we have any more questions, folks? No? This is actually the most timely, only because I know you have a short period of time.
Oh, that's okay.
Jordan, did you have one final question?
Yeah, yes, ma'am. Miss Julie, I wanted to see if you could share the golf tournament with your network because it's a national event and I'm trying
Oh.
to get as many people involved as I can.
I'd be happy to.
Thank you
So-
so much.
You saw my email, didn't you?
Mm,
On the slide?
no, ma'am. Let me write it down though.
Okay.
You want to put it in the chat?
Oh, yeah, I can
Julie?
do that. Mhm.
Okay, okay, we'll do that.
So Lynn, this is Mark Halverson,
Oh, hi, Mark.
and Julie, I've known Julie for years, man.
Oh,
Well,
We
we're
served-
both,
we
we're
served on the
both very
brain-
young.
Well, we served on the Brain and Spinal Cord Trust Fund, and Cassandra was telling me about Jules coming on, and I'm just so excited. I was excited that you're at the CDC, really, yeah. Because now we have it, and one of the things I gotta tell you on the, when I had my injury back in '99, it was 28% that TBIs were caused by falls. Well, now, going back to the research you've done, we're up to 35%.
Yeah,
I'm a prevention guy. I don't even want these injuries to happen.
I agree.
And I'm all about prevention, but the thing is, from a neurobehavioral standpoint, my speech therapist, Renee Mills in the Seminole Spirit, lives in Denver. She's a program director, learning services, who just acquired Restore Neurobehavioral Center.
Mhm.
And Restore is, you talk about youth and brain injury, and you've done all the work, but neurobehavioral issues, post brain injury, be it with the pediatric kids
Mhm.
or older folks. And I even say Navy veterans like myself, big deal, post brain injury. And I am so glad to see you here, Julie, and I hope you're doing good. Yeah.
Oh, thank you. Well, I appreciate, you are all, the taxpayers pay my salary, so thank you. And I continue to work at this national level, but I really, really enjoy joining groups like this and talking with people like yourselves who are living with this experience. It really informs our work. So thank you very much. And I'm afraid I must log off for today, but feel free to connect with me.
We'll do it.
all
Hi,
right.
excuse me, can I ask one last question?
Sure.
Do you have the time? My
Yeah.
name is Greg. I apologize. I wanted to be on here at 3, but I had to take my kid in for treatment. My question revolves around the emotional behavioral side of
Uh-huh.
pediatric TBI, with major depressive disorder and suicidal ideation and self-harm. Do you know of any new research that's being done along those lines, or treatment to facilitate recovery? Because I've been all over the country for 7 years seen some of the top people in the field, and we're still basically where we were when we started. Well, that's not true, but
Well,
the opportunity to end someone's life isn't in a moment's notice, and I've got him in ketamine treatment right now because
Yeah, thank you for your question about that. That's a very important issue. At CDC, we have a whole team working on overall suicide prevention and what they're trying to do. We want to apply to all individuals in the country, but particularly after TBI, when people's mood changes or they're more isolated, it's very much a concern. There's some research coming out, and I think what I tell families is the main thing is after the TBI, you need to monitor your children, know what they're doing, know how they're feeling, and make sure if they're not feeling well, it sounds like you're looking for care. And that's, access to care is an issue. So keep pursuing the care to make sure they're taken care of and they feel good about themselves.
we've been doing that, but I'm really looking for, a Hail Mary pass, some kind of remedy, some kind of treatment that might aid in that if you're aware of anything.
I'm not aware. You can look at cdc.gov at suicide prevention. They may offer some treatments. I'm not aware of anything specific in that area.
Okay,
I'm
Thank you
happy.
very much, everyone.
Thank you, Julie. I'm happy to stay on the phone and share some of the info. Caller 407, I don't know your name. That was just on. I went through that with both of my daughters, with the one more severe with her suicidal ideations and cutting, and both with severe anxiety. There is no Hail Mary that I came across, just to cut to the chase. But we know two things. One, cognitive behavior therapy that was structured very much in PTSD work. It's a very difficult therapy, and it took 3 therapists for me to find somebody who actually even offered that. They did it a lot with veterans, and Robert also linked in here on the chat, which I'm happy to share. You can email me and I'm happy to share all this information, but Robert mentioned about hyperbaric oxygen chamber therapy. And that's a legit issue to consider as a Hail Mary too, because in the data, one of the things that we saw with the patients who have suicidal ideation, they're tracking, the number one problem they have is transportation. And everybody said, oh, access to transportation, but that's wrong. They all wrote in their journals, they don't want to get into a car or on the subway or on a plane to go to a doctor because it shakes their heads. And depending upon where they're hit, frontal lobe mostly has a larger propensity to the suicidal ideation. So I did a big talk for the Massachusetts Disabilities Department about that. So we know that that exists. So if you're able to start to identify those triggers for your son, I believe you said, it will help you. And you can use the caregiver track. It's all free. But and if you email me, since you're on the phone, I don't know that you have access to the chat, but hyperbaric oxygen chamber therapy. You do? Okay. Then can you
No,
might. Oh, okay. You do not. But it will also, again, it's all about reducing inflammatory properties in the brain. And again, this is where it's very unknown. The question mark exists. Like, what is it that should be done first?
well, can I ask you a follow-up question? That he has done 40 dives at
Wow.
1.5. And I thought it did have some help. I wanted him to do more, but it's quite a commitment. You had mentioned the cognitive behavioral therapy. I've gone through a number of therapists and they just don't get it. Outside of one that I had out of state, but we moved. Do you know anyone in Georgia who has extensive experience in TBI and pediatrics with the kind of profile I briefly shared?
I do not, because I'm in Massachusetts and I was in Charleston, South Carolina, but I will give you a person that I brought my daughter to, and perhaps she might be able to find somebody who uses the same technique that she did.
I appreciate that.
Sure. You have my
Thank you.
email. You can just go to the
I do not.
website. Okay, what's your email?
Mine is Greg, G-R-E-G, Tucker, Tucker, at bellsouth.net.
bellsouth.net. All right, Greg Tucker. I will see what I can find for you.
Thank you.
Is he in Georgia?
Yeah,
Yeah.
Get in touch with the Brain Injury Association of Georgia, because that's what they do as resources, keeping up with what doctors.
have-
Yeah,
will
I've
tell
been
you-
in
I have,
touch
and I've
with
gone-
Greg.
Yeah.
Yep.
When I was with a counselor I went to for years, and I said, "How many people in Georgia do you know of, that are specialized?" And after a couple of weeks, she took it as a project, started calling all of her friends and stuff, and it was like under 25. That was to the entire state. And it was he goes, "You wonder why there's a problem, because there aren't enough people." I went to like 6 folks that just went, "Oh, there's nothing wrong with you." And you're like, "Trust me, it all changed in one afternoon." But it took me a while to find someone.
Hi, Waring. Yeah, this is Cassie. Yeah, Greg and I have been in contact and we have been searching. It's drilling it down to for young, adolescent and that hit the subset age.
Mm-hmm.
And it's the talk therapy. It's not finding the right one. There's lots of neurocognitive, but we just can't seem to find the right one. Would you agree, Greg? Like you and I both have been calling, emailing, searching. I don't know.
Without question. And I think a big part of it is, for instance, we came out of Florida, and his neuropsychologist is former president of the Brain Injury Association of Florida, but he understood the aspect of you have to treat this also as a brain injury, because that's what bringing about these profiles and these behaviors. So when you go to someone and they don't have the experience, they go back to what they know. And it's very easy to get up to date if people want to dig hard enough. If you get on any Facebook group, and I'm in 27 of them to learn and share, you wouldn't believe how many people put in there, to their credit, "I think about killing myself every day. I have this major depressive disorder. I can't get out of my head that I'm going to harm myself." And sadly, I just read a story about a young lady who tried to self-harm or kill herself 22 times after a head injury, and finally she succeeded in that. So it's real and it's prevalent, and trying to find someone who's capable and cognizant of the problems these kids have and have a real strategy, that's the problem. Because if you're going to sit there and tell a kid, "Hey kid, there's nothing wrong with you, this is something else," then you're going down an avenue that's completely wrong. And that's why I'm really searching. And the people I speak to, I ask them about their background, I ask them specific questions. And if they answer in a manner that I don't think is accurate based on some of their experts I've spoken with, you have to move on. So if anyone knows of anybody, please share. I'd love to hear about it. Thank you.
yeah, I will ask my daughter, and I will ask for the therapist as well and send that to you. And hats off to you for standing up for yourself. I mean, I did the same thing, physical therapy docs that we were sent to for Natalie had no clue. They were literally shaking her head violently and her knees are buckling. She couldn't endure any of that. And that was what they called vestibular therapy. So I got to the point where I would say, listen, if you have more than a weekend course, I'll talk to you. But if you don't have a weekend, if you don't have a real certificate or a track in your work that you actually know this, don't waste our time. Yeah.
I have to jump off, but Greg, I'll follow up with you. We have a meeting with Shepherd and their neuropsychology department next Wednesday on this adolescent program and exactly what you're talking about. I'm going to see if they can help us out. I mean, they are neuropsychologists. Let me see what I can do. I mean, I'm still trying to find something. So hang in there with us.
Just this last statement I'll make is, coming up here, some of the doctors in Florida said, "Oh, you're going to have a great time in Orlando," because Atlanta has so many great places. And I think I've learned that maybe if brain injury is your passion, you're at the Shepherd Center or you're at Emory or you're at Children's. But if you don't go in and you're involved and you're part of their inpatient program, as an outpatient like us, we don't have access to that. But I think that makes it more difficult. Some of the best people are already at these major hospitals, and they're not functioning in private practice.
I agree with you. I'll bring it up. I mean, I'm not afraid to. I'm in here. I'm a new gal, right? So I'm just going to start asking questions and act like I don't know what. Oh, sorry, learning curve.
And listen, I'll follow up too, because I'm meeting Shepherd the last week of March
Yeah.
as well. So I'll bring this up specifically with the outpatient aspect. I will be your voice.
Yeah, I haven't given up,
Thank
Greg. I'm still looking. But I'll follow up with you as well. Let you know how this goes and what else we can come pull together for your son.
Yeah. All right, everybody. This was great. I appreciate you
Lynn,
all.
I got a question for you, Lynn.
Sure, Mark.
So I was in a meeting with you last week and you did a great job. And I was telling Cassandra, I'm a swimmer. I was a born swimmer. I'm an open water swimmer. I swim for brain injury.
Oh, wow.
Yeah. So here's my question. Your daughter was a swimmer. She had a traumatic brain injury.
Mhm.
Tell me, has she gone back into the pool and swam?
She tried twice and the pressure was so severe the first time that she couldn't finish the lap, so we had to get her out. The second time she got down one lane. This was after she did a lot of her vestibular and her vision therapy, but she was not really correct yet. Like she still had a lot of therapy to go. So in her second attempt, she couldn't see the line right. And so it was making her start to have massive migraines. So she only tried twice, but that's it.
Now, let me ask you this. How far post is she?
See, it happened in 2015. So she's 7 years post now.
Okay, so her Glasgow, I mean, she was severe, right?
Yeah.
Yeah, so sometime down the road, if you want somebody to talk to her, I had to relearn how to do the flip turn, big deal. But the problem is swimming in an open water is different than in a pool, but therapeutically, it's the best exercise you can do for your brain.
Mhm.
And I'm out, forget the injury for a second, but it's the best exercise anybody can do for their brain.
Oh, yeah.
And I'm a big advocate on it. I run a nationwide support group and we got open water swimmers in our group. But I anytime you wanted to talk more about it, I'd be willing to do that and share with you. And
Yeah, I would, because Hannah's a former swimmer as well. Hannah, who's on the call, she's our public
hey, Hannah.
coordinator. And I had said to Hannah, it'd be really cool if we could run a team swim event,
Oh, yeah.
a take two event where you swim either with a partner or you tag a partner or something like that. So I'd love to definitely speak with you about that.
Absolutely, it'd be great, Hannah. And how long have you been swimming?
I swam for like 14 years. I swam collegiately too, and then
What school?
Oakland University in Michigan.
Oh, I know Oakland University. Yeah, my niece went there and
Oh,
got her
awesome.
master's in special ed, and she's up in Grand Rapids now. But yeah, I know Oakland. I've heard of Oakland University. So yeah, that's great. But I mean, I'm so passionate about the swimming for brain injury. It's like, so there'll be more fundraisers coming and helping people recognize or make people aware that water is good. Because as I would say to Julie, she's not here anymore, but there is no falling when you're in the water.
Yeah. Yeah. Touche.
Well, you guys this has been great. I really
Yeah.
appreciate being part of this.
All right.
We'll be in touch.
Okay. Thanks, everybody.
Bye, guys.
All right. Have
Yeah.
a great Wednesday.